We are live.
Good evening, all. Welcome to iFocus Online, the 372nd episode, 47th in the Oculoplasty module. Today, we have an international masterclass by none other than Dr. Bita Esmaeli from the MD Anderson Cancer Center, Houston, Texas, United States. She's going to speak to us on mesenchymal tumors and histiocytic tumors of the orbit. She, though, does not need any introduction, but for the viewers across the globe, she is a professor and a fellowship program director for ophthalmic plastic surgery at the University of Texas, MD Anderson Cancer Center. Her areas of interest include orbital tumors, lacrimal gland carcinomas, eyelid cancers, melanoma of the eyelid and conjunctiva, and reconstructive surgery in the periocular lesion, including the lacrimal and the orbital surgery. Her research interests include early detection of metastasis, multidisciplinary eye sparing approaches, molecular targets for treatment for ocular and orbital cancers, neoadjuvant treatments for the adnexal cancers. Authored over 320 peer-reviewed manuscripts, over 60 invited articles and book chapters, and has spearheaded numerous clinical trials and research protocols at the MD Anderson Cancer Center. She is a recipient of many prestigious awards and honors, including the Merrill Pathology Award and the Research Award from the American Society of Ophthalmic Plastic Reconstructive Surgery, the American Academy of Ophthalmology Senior Achievement Award, Best Doctors in America and the Top Doctors Award, the American Association of Cancer Research Team Science Award, and the Educator of Quarter Award at the Cancer Center, and the Hughes Award by the Esopris in 2022. It's a pleasure to have you, ma'am, on our platform for tonight's talk. Over to you.
Thank you. Thank you so much, Sabha, for this warm introduction. Thank you, Dr. Hanover, for the invitation. It really is an honor for me to participate. I'm going to share my screen and see if I can do this well. And let's see. Here we go. Are you able to see my screen, Sabha?
Yes.
Yes. Okay, fantastic. So without further ado, this is a topic that I actually had to work on this lecture a little bit because it is a relatively rare cancer in the orbital area, and I wanted it to be a comprehensive review. So it's one that sometimes is ignored by most curricula. But I wanted to go over some general information and then kind of hone in on individual entities. So let's start with the title, orbital mesenchymal tumors. These are soft tissue tumors. And the malignant variety is really referred to as sarcoma. So I think if you're reading in cancer realms, the word sarcoma really refers to these malignant mesenchymal tumors. And of course, they can occur in the orbit. Let's look at some statistics. The sarcomas in general account only for about 1% of all solid malignancies in humans. So it's really a very rare entity. And only about 0.4% of all sarcomas occur in the orbit. So to put it in perspective, this really is a very rare entity. And if you look at it a different way, the most recent statistic that I could find that is referenced a lot in the United States is from the year 2014, so kind of dated. But it's estimated that only 12,000 new cases of soft tissue sarcoma are diagnosed, and 3,000 bone sarcomas are diagnosed each year. And less than 1% of all cancers in adults are sarcomas, but a higher proportion in children. So 15% of childhood cancers are sarcomas. So that's important to note. And if you look at it anatomically, only about 10% of sarcomas or malignant mesenchymal tumors occur in the head and neck area. And again, only 0.4% in the orbit. So if you kind of do the math for population of the United States, now in India it would be a larger number because you're a more populated country, and throughout the world depends on the populations. But something like only 50 new cases of orbital sarcomas would be diagnosed each year. So again, extremely rare cancer. But despite its rarity, I think we're all familiar with it because if you work in a referral center, you're going to come across these various entities. This table, very busy, but really shows you the breadth of various different terminology given to various different forms of soft tissue sarcomas. And it also reminds us what we mean by soft tissue mesenchymal tumors. You can have adipose tissue, fatty tumors, fibrous tumors, skeletal muscle, smooth muscle, blood vessels can be the histology of origin of these tumors, cranial nerves, peripheral nerves, cartilage, bone, and of course some unclear, uncertain histologic origin. And the red lines are entities that at least I have come across in my practice of 26 years at MD Anderson and have read about in the literature, in the ophthalmic literature. So the red ones are the ones that we do see in the orbital area. Now, it's not an exclusive list. It's quite possible you will see other varieties listed here in the orbit that I haven't really highlighted in red, but any of these are fair game in the classification of mesenchymal, malignant mesenchymal tumors. And another sort of broad theme is that these lesions, at least we should consider multimodality management, because in the orbit, the focus does need to be on organ preservation, on orbital, decreasing orbital morbidity, and trying to preserve the eye and its function. So using multimodality management approach can lead to a higher likelihood of ocular and orbital preservation. But historically, surgery, of course, would be preferred if it's possible for all soft tissue sarcomas. But if we use the analogy of limb salvage, because soft tissue sarcomas are more commonly seen in the extremities, there is a lot of emphasis in using multimodality management to try to do limb salvage, meaning avoiding removal of upper or lower extremities. Similarly, in the orbital area, we should try to use, and we have been using multimodality treatments to try to avoid an orbital exenteration or loss of function of the eye. Here are some lesions that are felt to be chemosensitive. This slide is actually old. It's based on a paper we published some at least 10 years ago. But with the chemo drugs that were available at that time, these are the entities that are likely to have some chemosensitivity. Of course, importantly, you see rhabdomyosarcoma in our world, in the orbit. Rhabdomyosarcoma is quite chemosensitive, thankfully. As are some forms of malignant peripheral nerve sheath tumor. You may see Ewing sarcoma in the orbit happens, and it's chemosensitive. Angiosarcomas, if you see them in the periorbital region, they are chemosensitive, and on and on. So it's important to know, as you collaborate with medical oncologists, which lesions might be chemosensitive and which ones may not be. And then there's this, again, in broad themes, the issue of when do you give radiation, when do you give chemo? I think in a lot of the soft tissue sarcomas, neoadjuvant use is common, meaning after a biopsy is done, instead of going straight to exenteration or going straight to some definitive surgery, there is a general theme of using chemotherapy or radiation therapy prior to definitive surgery, again, in an attempt to do less surgery, so that the definitive surgery is less radical, less morbid. So this common theme also applies, and it's really the basis behind the way we treat orbital rhabdomyosarcomas, for as an example. And I'll try to show some examples of other forms of sarcoma where this neoadjuvant approach, meaning prior to definitive surgery, might make sense. And for radiation, at least, when you do neoadjuvant radiation, most radiation oncologists that treat soft tissue sarcomas give a lower dose and a smaller field, and that can be advantageous in the orbit. Okay, so let's start looking at some specific entities. And Subhav, if I may ask you to give me like a 10-minute signal for the end of the hour so we can entertain questions as you suggested. I'm just going to go through cases now and just bring out some specific take-home messages for orbital malignant soft tissue sarcoma. So we're going to start with pediatric rhabdomyosarcoma. This, of course, is the most common malignant pediatric tumor in the orbit. Again, I highlighted just how rare these entities are. So even though we refer to it as the most common primary malignant cancer in pediatric population in the orbit, it still is a rare entity. And it is rhabdomyosarcomas in general account for about 50% of all soft tissue sarcomas in the birth to 14-year-olds, but it's still quite rare in the orbit. And we can also see adult onset rhabdomyosarcoma. I certainly have that in my practice, but it's less common, right? Only about 5% of cases are adult onset, and those have worse prognosis than the pediatric rhabdomyosarcomas. So this might be a typical case, a 5-year-old little girl, otherwise healthy, doing fine, but all of a sudden, in a kind of a rapid way, is getting some congestion and edema in her upper eyelid. We tend to think of the superior medial quadrant of orbit as being the most common area. You can see rhabdomyosarcoma, but it can occur anywhere in the orbit, really. Any place you have muscle and nerve and soft tissue, you can get rhabdomyosarcoma. And so this should prompt this type of presentation, and usually children come from emergency rooms with a CT scan, although we try not to do CT scans in young age. Typically, the very first imaging study they have is a CT scan because it's fast and it's readily available. And so the appropriate thing to do is a timely biopsy. Now, in this particular case, most of the lesion was removed because it was accessible. It wasn't in a location that was particularly difficult to get to, or there wasn't a risk of damage to surrounding structures. So most of this lesion was removed. And on special staining and on histologic evaluation, it was a case of embryonal rhabdomyosarcoma, which is the most common variety, garden variety, orbital rhabdomyosarcoma. And as always is expected, present at tissue edges, because if you're going to do a wide excision, you're going to end up damaging muscles nearby and important structures nearby. So most of us wouldn't aim for a wide excision of these lesions because you know that the patient is going to have to get chemotherapy and radiation therapy. So immediate surgical biopsy is appropriate, debulking if there isn't much morbidity associated with it, and then chemotherapy and radiation therapy is appropriate. Most cases take about 6 to 12 months for treatments to be finished. And there should be more than 90% cure rate with very good quality of life and ocular function. An occasional patient will get a cataract from the radiation, but there shouldn't be significant corneal toxicity or other ocular toxicity with the modern techniques of radiation therapy. And the need for orbital exenteration is rare. I would estimate at less than 10%. And it's really only appropriate for resistant cases that are not responding to chemo or radiation and are still recurrent or resistant. And I will try to show some examples. The prognosis is very good for patients that present between the age 1 and 9. Those are the best prognosis group. Orbit in general is viewed as a favorable site, and tumor size matters. So lesions that are less than 5 centimeters in diameter, this is true for all rhabdomyosarcomas, have the best prognosis. So by definition, when you have a lesion in the orbit, it's most likely going to be less than 5 centimeters, and it's going to be favorable in terms of prognosis. And of course, again, this issue of resectability is one that can become tricky and controversial. How often can we really fully resect an orbital rhabdomyosarcoma? I think Most authorities would agree that you're always going to have some microscopic disease left behind after the surgical debulking or biopsy procedure. And therefore, multimodality management with chemo and radiation is really, really important. The molecular classification is very important. So fortunately, most cases of orbital rhabdomyosarcoma are embryonal in variety, and that's the best prognostic group. But alveolar rhabdomyosarcomas can also occur in the orbit. They have a worse prognosis, but still we can be optimistic that with the appropriate chemo regimen, appropriate dose of radiation, the majority of those cases also could do well with appropriate treatment, if in the orbit and in the right age group, right? There's a lot of things that go into factors that go into the prognosis. And for alveolar variety, there is chromosomal testing that can confirm the diagnosis. That's really the basis for calling it alveolar, is based on these translocations in chromosome 13 and some other varieties of chromosomal changes that are summarized here in this slide. And the pathologist can tell you with some certainty that whether it's predominantly alveolar or predominantly embryonal. There are also cases that are a mixture of the two. So alveolar, as I mentioned, has a worse prognosis compared with embryonal. But still, you can be optimistic that you can have a nice outcome. This is a case of a 6-year-old boy that presented, again, with a supromedial mass on biopsy. It was an alveolar rhabdomyosarcoma, intermediate risk, and still got chemotherapy, probably a different chemo regimen that we would do for embryonal rhabdomyosarcomas. He still got proton radiation therapy and did very well. I followed him for 5 years, and he's without evidence of disease and has good ocular function. So it is not an absolute failure in outcomes when someone has an alveolar rhabdomyosarcoma. But of course, it is a worse prognosis in general. Here's another kind of atypical case of rhabdo. This is a 13-year-old. Again, these patients fall outside. This patient falls outside the good prognosis age group. A 13-year-old, relatively the worst prognosis because of the older age of onset. And this is a patient that actually presents this time with a superolateral mass and progressive proptosis. Now, for all the world, it looks like a lacrimal gland lesion. In fact, I thought it's possible it's a lacrimal gland adenoid cystic carcinoma, because that also occurs in this age group. And but in fact, it was a mixture of embryonal and alveolar rhabdomyosarcoma on histologic evaluation. And this patient was treated with some debulking, then chemo and radiation, and did very well and has remained disease-free after 5 years. But there are cases where we don't have a good outcome. This is a child, 5-year-old, was treated initially in another country, in Venezuela, and presented with a recurrent, heavily treated orbital rhabdomyosarcoma. Unfortunately, this child had a delayed diagnosis and multiple sort of incomplete treatments over the course of several prior year or two. Chemotherapy, but no radiation. Then surgery, but a little bit of chemo, but no radiation. Then eventually radiation, but multiple recurrences, unfortunately. But importantly, initial delayed diagnosis. This was the imaging studies shared with us at the original presentation at an outside institution. And this lesion was felt to be a lymphangioma. And without a biopsy, this lesion had even sclerosing agents prior to referral, and unfortunately, then this got delayed diagnosed and even had sclerosing agents before a biopsy was done. So really, really important to have a high index of suspicion and do the at least a biopsy procedure to rule out rhabdo in childhood rapid onset lesions like this. And this child did not do very well. At the time he presented to us, this was the picture. He still had some chemotherapy, some response, but multiple recurrences, and eventually a very poor outcome. So this question then comes up: how common is it to have a residual mass after we do the usual treatments for orbital rhabdomyosarcoma? How long should we expect for a mass to go away? What should we do about a residual mass? These are some questions that I think often come up, mostly for specialists that treat rhabdomyosarcomas. So we asked this question in a recent study, and most of the patients from MD Anderson, but there were 3 other universities that contributed cases. These were all cases that had of orbital rhabdomyosarcoma, and we essentially concluded that about a third of the times, after appropriate treatments are done, including chemotherapy and radiation therapy, there will be a residual mass that you can see on imaging study. And the goal was to figure out, okay, what do we need to do about this? Do we need to commit the patient to an exenteration every time? Or is there some variation of the theme? Can we figure out how often this is a bad sign, and how do we deal with it? So as it turns out, out of these group of patients, 4 of these residual masses actually spontaneously disappeared over time. 3 of them were re-excised, and 1 progressed to eventually requiring an orbital exenteration. So this gives us some idea. And 3 of them were still present, but inactive and dormant and stable. Some of them as late as 7 years out of treatment. So important to remember that. And how do we evaluate that? Is with serial observation and vigilance on imaging studies to make sure that if it becomes progressive, then you may consider an orbital exenteration. And again, we try to figure out what are some good guidelines for knowing which patients require increased surveillance. And generally speaking, for patients who are having chemotherapy and radiation, the 12-week mark seems to be a really good indicator. So if you have a patient that at 12 weeks after chemotherapy, and by then they may have had radiation, they may not just be starting radiation therapy. If by then they still have a big mass remaining, there's a pretty good chance that's the patient that may end up with a residual mass. And you have to be really, really vigilant about following those patients more carefully and more closely, because some of those patients will eventually progress. They have an unusually aggressive orbital rhabdomyosarcoma, and they will have to be treated with additional treatments, additional interventions. That's sort of a rule of thumb. Other findings from this study that was published in American Journal of Ophthalmology a couple of years ago is that there was really no significant difference between patients that had incisional biopsy or those that had an excisional biopsy at the time of initial diagnosis of orbital rhabdomyosarcoma. There was really no difference. The main difference is how they're treated afterwards. How do they get the full chemo dose? Do they get radiation therapy, which is appropriate in the overwhelming majority of patients? And also T category matters. So, I'm pleased that the AJCC T category holds. For those of you may not know, there is actually a T category for orbital sarcoma in the AJCC manual. So it's actually, as rare as orbital sarcomas are, we do have our own T category dedicated to orbital sarcomas. And it does seem to hold in terms of its prognostic value. And if we want to look at numbers of just how often patients actually required exenteration because of continued progression, it was 4 out of 33, so just about 10% or so. And 2 patients died of disease, 2 out of 33. But important to also note that in this group of patients, there were 3 adult rhabdomyosarcoma patients, and those 3 came from MD Anderson, and those are the ones that have a worse prognosis. So important to keep that in mind. So if you're purely treating pediatric rhabdo, the prognosis should be even better than this. Here's a kind of interesting recent case in terms of sort of management dilemmas. An 8-year-old boy had embryonal rhabdomyosarcoma, already diagnosed appropriately, treated appropriately. He had 6 months of chemotherapy, and finished proton radiation therapy at another institution. But the reason for consultation is the orbital mass is not going away. What should we do? So at the time of this presentation, he looks like this. He's had radiation. You see the skin color changes from radiation. You see that he's lost his hair from chemotherapy. This is his imaging study at the initial presentation to another institution. The lesion is fortunately in the lacrimal gland area. I say fortunately because that's an area that we are comfortable doing surgery for, at least in the last 15 years or so. There is an emphasis on eye-sparing approaches for lacrimal gland carcinomas. So his original lesion was in the lacrimal gland area and looked like this. But after chemo and full chemo and radiation dose, he ends up with this residual mass. And what should we do about this? You know, the initial recommendation at the previous institution was to do an exenteration, but we were reluctant to do that because it seemed like he had had a good enough response. And on PET scan, this wasn't an active lesion. So we were hoping that this would be a dormant, mostly non-viable tumor. So I actually, after much deliberation, I elected to just do gross total resection of this lacrimal gland lesion without an exenteration. We have a few years of follow-up on this child, and he's doing well. And I'm fingers crossed, I hope that he will continue to do well. But for him, it's a big difference between exenteration and eye-sparing surgery, and for the rest of his life. And he does, of course, need to be followed very carefully over the long run. So in summary, as rare as it is, I think orbital rhabdomyosarcoma remains a very important entity for an orbital surgeon, for an ophthalmologist. There is a really important need for immediate diagnosis. Correct and immediate diagnosis is really, really important and makes a difference in terms of final outcomes. The overall prognosis is actually quite good. More than 90% cure with preservation of the eye and good function for the eye. Some attention to cataract formation and early diagnosis of cataracts, and therefore, particularly in the amblyogenic age group for patients, is important after radiation therapy. The embryonal histology and age between 1 and 9 years at diagnosis have the best prognosis. About a third of the cases may end up with some kind of a residual mass after even appropriate treatments are completed, but that does not necessarily mean treatment failure. So I think careful, judicious considerations for those residual lesions is appropriate. And there is really no difference, it seems, in terms of treatment outcomes, whether you do an incisional biopsy or a debulking or excisional biopsy. What's really important is what is done next: appropriate chemotherapy and appropriate radiation therapy. And the 12-week mark seems to be important in terms of evaluating treatment response. And when there is a residual mass at 12 weeks, those are the patients that need to be followed very, very carefully, and additional interventions may be necessary. So that was my last slide on rhabdo. I'm going to start showing you some other entities in the realm of malignant mesenchymal tumors. It's a case-based presentation, so we're just going to, so in my practice at least, the second most common lesion that I encounter is this entity. So this patient, 38-year-old, happens to come with a right lacrimal gland lesion, has some fullness in the upper eyelid, 7 months in duration, slow increase in size. Her visual function is okay. She has some proptosis, as you can see. This is the imaging study in her. It's a fairly well circumscribed mass, but it does have some sort of heterogeneous enhancement features on MRI. Well, it could be a pleomorphic adenoma, it could be a lacrimal gland carcinoma, but as it turns out, this was a case of a solitary fibrous tumor or hemangiopericytoma. And it was fully resected. And of course, the latest terminology that's preferred by WHO is solitary fibrous tumor. There's pretty good consensus that these are the same entities, slight variation in findings on histology, but by and large, the preferred terminology now is solitary fibrous tumor. And the final path on this lady was, she had negative margins, but of course your margins are always going to be close in this situation. PET was also negative, and she had very few mitotic figures. So this is a case of a non-malignant hemangiopericytoma, or preferred terminology, solitary fibrous tumor of the orbit. And this is in the realm of mesenchymal tumors, and it's actually a fairly frequent encounter in an orbital referral practice. Let's look at another case. This patient now presents with 6 months history of, again, a lesion this time in the supermedial orbit. And she has already had an incisional biopsy that showed at an outside institution. It showed a lot of mitotic figures. It is a solitary fibrous tumor, but it has 9 mitotic figures per 10 high power feet. And this is a relatively high mitotic figure rate. It's concerning for malignant transformation. She's then referred to us. She's already had an incisional biopsy, meaning that there could be some seeding in the orbital area. So this one is not as straightforward exactly how to manage. Should we do eye-sparing surgery now? Should we do orbital exenteration? Because after all, she has a lot of mitotic figures. Should we do neoadjuvant radiation followed by surgery? Or should we do surgery followed by radiation? Does chemotherapy work? So these were the possibilities. And after discussion at our multidisciplinary sarcoma conference, the consensus was that let's do neoadjuvant, meaning prior to surgery, radiation, because in that setting, there's less radiation given. Instead of the usual 66 grays that would be given post-op, only 50 grays are given, with the plan to do surgery 4 to 6 weeks after radiation's finished. We've done this now in a few cases of recurrent solitary fibrous tumor, and radiation can also lead to some decrease in size of the lesion in some cases. I want to emphasize this because it's not in every case, as I will show you in a moment, some variation of the theme. In this particular case, we went from 25.5 millimeter in greatest dimension to 19.4 millimeter in greatest dimension after radiation therapy. So there was a 25% decrease in tumor size after radiation, and then surgery was done. This patient, I have a couple of years of follow-up, and then she was lost to follow-up because she's from another state, but I have not heard back, so that usually means that she's getting follow-up care locally and has not had a recurrence. I certainly hope so. But in these cases, you have to be very hypervigilant for additional recurrences over time. Here's another case. I had the opportunity to see this patient. This is the older patient of mine. He has passed away due to other causes, but he had had several recurrent lesions. These are solitary fibrous tumors that he had experienced as recurrences over several decades and had had multiple surgeries. Presented with this lesion that you can see again in the medial orbit, extends fairly posteriorly into the muscle cone. And in this case, again, we elected to do because it was recurrent, multiple times recurrent, and I wanted to do something other than just surgical resection. I wanted to consider radiation, and the consensus was that let's do radiation up front in a neoadjuvant setting before going to surgery. So he had 50 grays of radiation. In this case, we had a 75% decrease in size. So this was a remarkable case. Actually, we published this at least 15 years ago. It's an older case. So a really dramatic response in size of the lesion after radiation. And then, of course, we did surgery. This patient's still not done with recurrences. I never would think that means that he's never going to have recurrences. But if we can buy him another 10 to 15 years, that's still good. And he managed to still keep his eye. And importantly, his tumors did not have high mitotic figures. If he had had highly mitotic solitary fibrous tumor, we would be worried about malignant transformation. And we would also have to be vigilant about working him up for distant metastasis, because that does occur, and consideration of chemotherapy in case he gets distant metastasis. This slide shows you his mass at the time of surgery, which was just 25% the size of the original presentation. And these are some of the classic stains for solitary fibrous tumor, BCL2, CD34. And of course, you can see the mitotic figures, not too many in his particular case, but some of them have much more malignant features, and those need to be much more carefully treated. Another recent case, 76-year-old, this patient's from Hawaii, traveled for management of his lesion he came all the way to Houston. He had already had, so again, the typical slowly progressive proptosis over the course of 9 months. He had already had a biopsy, incisional biopsy, that showed solitary fibrous tumor with only 1 mitotic figure per 10 high power field, so not terribly malignant in nature. This is the imaging configuration of his mass. So an intraconal mass, it extends fairly posteriorly into the orbit, and multilobular in nature. So again, for him, and it has already had an incisional biopsy. So, I think that, there is seeding in the orbital soft tissue. So I wanted to consider radiation for him. I thought, if it shrinks it, that's good. The surgery will be a little cleaner, a little easier. And if it doesn't shrink it, it might still be good, because maybe it'll have at least it'll have less viable tumor cells and perhaps less likelihood of recurrence in the future or seeding. So this is what happened with him. Here's a pre-radiation imaging, and here is post-radiation imaging. If anything, it really didn't change. So in this particular case, I showed you a couple of examples where it did shrink. In this particular case, it really didn't shrink, but I still took him to surgery. And I feel that even if it didn't shrink, it did make surgery a little easier, because some of these lesions are quite friable and they come in little pieces. In his case, it really had a more fibrous nature, and it came out nicely. And at least some radiation oncologists believe that radiation can have that effect on these tumors, but you must operate within 4 to 6 weeks of radiation. If you wait longer, it may actually be more difficult, because there's a lot of fibrosis, late-stage fibrosis, that makes the surgery more difficult. This patient, I have about 6 to 9 months follow-up, and he's doing well. So in summary, I think probably I would say the second most mesenchymal tumor we see in terms of frequency is solitary fibrous tumor, and but still kind of rare, but it's slow growing. Most of them are benign, and I think, but the ones that have high mitotic figures, and that might be considered greater than 4 mitotic figures per 10 high power field, you have to be vigilant. You have to do a PET scan or a CT of chest, abdomen, and pelvis, and understand that they can in fact recur both in the orbit and also lead to distant metastasis and potential death. But that fortunately is a uncommon occurrence. We found a series of patients with malignant solitary fibrous tumor in my practice, and we published it in OPRS in 2018. You can read the course of those patients in that paper if you're interested. So I'm going to switch gears again to another entity that you're likely to see. As rare as it is, it can still occur in most referral practices. You will come across this, and that is Ewing sarcoma. Ewing sarcoma can occur in the pediatric population or in adult population, young adults. Here's a case of what we would consider a primary Ewing sarcoma. It really is a nasal, sinonasal, and orbital Ewing sarcoma. Presents with proptosis. This is, again, another patient from far away. He lives in Puerto Rico, and he's a long-term survivor. He sends me Christmas cards now, but he presented like this with a large mass in the with orbit and sinonasal cavity. It's unclear where it started, but it involves both the sinonasal cavity and the orbit, and he has severe proptosis. biopsy has already been done. We know that it's a Ewing sarcoma. And Ewing sarcomas, fortunately, are sensitive to chemo and radiation. This patient was treated with chemo and radiation. You can see that his lesion is gradually going away. And here he is after radiation, has some skin color changes. His proptosis is going away. As I mentioned, I followed him for 5 years, and he's a long-term survival. He's still a survivor. He lives in Puerto Rico. I no longer see him. I followed him for 5 years, but he sends me Christmas greetings, and he's still doing very well. Here's another case. Well, importantly, chromosomal analysis for Ewing sarcoma can be quite nice in terms of confirming the exact type of sarcoma on chromosome 22. And that can be important diagnostically. And there are significant advances made in chemotherapy, and overall, the prognosis for Ewing sarcoma has improved, and more than 50% of cases do have long-term meaningful survival. I wanted to include this patient to say that primary Ewing sarcoma of the orbit is a rarity, but most often we can see Ewing sarcoma metastasis to the orbit, as was the case here. This is a patient with lower extremity sarcoma, Ewing sarcoma, metastasis to the orbit. These cases still need to be treated with chemo and radiation, and hopefully exenteration can be avoided in a patient that already has metastatic disease. Another entity that's important to remember is secondary sarcomas in a retinoblastoma patient. For ophthalmologists and orbital surgeons, this is an important entity to remember. So if you have a patient who has retinoblastoma, a history of retinoblastoma, and is a long-term survivor, they may present with a secondary sarcoma. This was a case of an undifferentiated malignant fibrous histiocytoma in a patient with a history of hereditary bilateral retinoblastoma. This risk increases if they have had orbital radiation. And of course, you're all familiar with the classic facial features of a adult who's had childhood retinoblastoma and has been treated with facial radiation to the periorbital region with this atrophy of the facial bone and lack of development of facial bony structures. So it's a classic case, and they are very prone to these secondary sarcomas. Studies suggest that the risk of developing a new malignancy 50 years after RB diagnosis is about 30%, 36% in the hereditary cases, and something like 5% in the sporadic cases of RB. And as I mentioned, that risk increases if they've had radiation therapy. And the most common secondary malignancy is, in fact, sarcoma. It would be an osteosarcoma of the bony walls of the orbit, or soft tissue sarcomas that we can see in retinoblastoma survivors. This is my final case, I think, before we close. I wanted to use this case to highlight the importance of expert pathology review. That is very, very important for sarcomas. At MD Anderson, and really for all mesenchymal tumors, because they're rare in nature, and there's so many different histologic varieties that have been named in the literature. But in fact, it can be really controversial what the exact entity is. At MD Anderson, we have a section dedicated to sarcoma pathology. And there are 3 pathologists that all they look at is sarcomas and soft tissue mesenchymal tumors. And so it's a very specialized field. And I think expert pathology review is really, really key. So here's a good example. This is a 71-year-old woman that really kind of brings this message home. This is a 70-year-old woman. She has 2 years history of progressive proptosis, so slow onset proptosis. And an outside MRI has suggested a destructive bony lesion, meaning there was erosion of the bone. This is the lesion that you see on MRI. They even got a PET scan that showed some metabolic activity in this area of this lesion. And a biopsy was done prior to referral. And it was read at an outside facility as being chondrosarcoma. Now, chondrosarcomas are really very rare in the orbit. They might happen in the floor of the orbit, in the setting of a maxillary sinus chondrosarcoma that might secondarily involve the orbit. So then patient gets referred to us, and we have this picture of a heterogeneous mass. Our pathologists look at it and say, you know, it is eroding the bone. It kind of emanates from the bone, but it's not particularly destructive. It's sort of nice and round. And our sarcoma pathologists, as a group, reviewed the outside pathology biopsy specimen, and they call it this. They don't give it a name. They don't say it's a sarcoma. They definitely don't think it's chondrosarcoma, but they just describe it. This is a sclerotic bony formation with intramedullary myofibroblastic proliferation with no identifiable malignancy. This is very good news for the patient. Of course, reluctantly, very hesitantly, I accepted this diagnosis. This is really not a diagnosis. It's just saying there's no cancer. We don't see any reason to call this a sarcoma or a chondrosarcoma at that. So very cautiously, I elected not to do an exenteration because that was what was originally planned for her. We decided to do very close serial observation. I did have 5 years of follow-up at that patient without any further progression. So thankfully, this was a correct diagnosis by our sarcoma pathology experts, and this was not a malignant case. So I think this case really highlights the importance of expert pathology review. So in summary, this is my final slide, and then we can entertain some questions if we have time. I think we do have time. We have about 15 minutes. Orbital sarcomas are rare, but they are really important, as I just highlighted. They come in a variety of histologies, and different names in the literature that may or may not be relevant, but the common entities would be rhabdomyosarcoma, solitary fibrous tumor, Ewing sarcoma. These are the entities that we most often see in the orbit. But of course, there's a wide variety of lesions you may encounter, both in the pediatric and adult population. Most patients benefit from multimodality therapy, which will include some chemotherapy, radiation, and surgery. Solitary fibrous tumors, the mainstay treatment is surgery, but judicious use of radiation might make a difference in some cases, as I showed you in my examples. And if we're going to do radiation for solitary fibrous tumors or for any sarcoma that is planned for surgery, you might consider neoadjuvant or pre-surgical radiation. This is something that I actually learned from my colleagues in radiation oncology at MD Anderson. This is not something that is in our literature, in the ophthalmic literature, but over the years, after 26 years of working with them, I have also kind of come to the understanding that neoadjuvant radiation for soft tissue sarcomas particularly might be advantageous because they give a smaller dose and a smaller field, and it might actually help you with your surgery. Some cases might shrink, some may not, but it's important to time your surgery within 4 to 6 weeks after delivery of radiation. I didn't show you examples of immunotherapy for sarcomas because its application is limited for soft tissue sarcomas, and particularly for the entities that we see in the orbit. So far, I'm not aware of immunotherapy being used. Maybe for some cases of liposarcoma, dedifferentiated liposarcoma, which is pretty rare in the orbit. But a recent case of angiosarcoma I had in the periorbital region that is being currently treated with immunotherapy and chemotherapy. I have not seen him back, but we're optimistic that there would be some treatment effect in him. Maybe next time I give this lecture, I will have pictures of angiosarcoma treated with immunotherapy and chemotherapy. That's an area of active study. And the other take-home message would be the importance of expert path review. In the United States, there are specific centers that have expertise for sarcoma pathology review. And I think that's probably also true throughout the rest of the world. Thank you very much for your attention, and I hope this was helpful. I'm happy to entertain some questions now, and I can stop sharing.
Thank you so much, ma'am, for such a lucid explanation of all the difficult tumors in the orbit. We have a few questions from our viewers. First question pertains to the solitary fibrous tumor. The question is, what is the expectation of reduction in the size of the tumor in SFT following radiation?
Yeah, so I have only really used this approach in a handful of patients. I showed you 3 of them. There may be a few more in my practice. I have published a couple of cases here and there. So I would say most radiation oncologists, based on their experience for soft tissues, for solitary fibrous tumor throughout the body, throughout all anatomic sites, they would tell you that don't expect shrinkage. But I have seen significant shrinkage. So I would say, I can give you percentages, but amongst the handful of patients, I would say at least half of them had meaningful shrinkage in size. But even if they don't shrink, in that one case that I showed you, that multilobular large mass, I felt that it kind of tidied up the edges a little bit, because as you remove these, they can come in pieces, and that's really not great because that leads to further recurrences down the road. So I think it might also have the added advantage of kind of making surgery a little bit less messy if you do radiation upfront, and they give a smaller dose. So if you think so my rule of thumb is, if a patient has a recurrent solitary fibrous tumor, or it's a particularly large one where I just don't think I'm going to get it all without an exenteration, I might consider radiation therapy. And if I'm considering radiation therapy, at least at our center, it's preferred to give it before surgery. But if you're going to do that, don't promise the patient is going to be smaller, but say it might get smaller. We've seen it before. It's been reported in the literature. Some patients have a shrinkage, but we don't know how much. But it might make your surgery easier. But then you must plan your surgery within 4 to 6 weeks after radiation's finished, because I think if you wait beyond that, although I haven't done it in that setting, or when you do, well, we all have operated orbits that have been radiated before. Those are really fibrotic, very difficult to operate orbits. So you must plan it within that acute phase before the long-term fibrosis has taken effect. So, those are kind of the sort of pearls in management, but can't give percentages. I think I usually counsel patients, 50-50. I don't know. It might shrink, it may not, but it's worth the try. And if we're going to do radiation, I'd rather give it upfront than give it post-op, because that's the preference of our sarcoma radiation oncology department, and it seems to have worked so far.
Ma'am, in a setting where radiation is being considered, so is it done with corneoprotection and neuroprotection as well?
Good questions. So, most modern radiation techniques, it's either IMRT or protons, right? These are really high energy radiation. So it can be delivered with eye sparing intent, meaning you can spare the cornea, but it's not like you're putting a lead shield or a obstructive shield over the cornea. It's all about how they plan it on their planning conference in radiation, where the isodose curves are and how much radiation is delivered to which part of the orbit. And that very much is dictated. This goes for all orbital tumors. That's very much dictated by the tumor configuration, right? So if you have a tumor that crosses the midline, goes in 3 different quadrants, that means that tumor and all of its extent has to be radiated. It's a question of how much radiation. And if that's 50 gray, 60 gray, comes really close to the optic nerve or crosses the midline, then the cornea may not be protected, right? So it all depends on the circumstances of that particular tumor. It's a very, very good question for all orbital tumors when you're trying to do eye sparing. When you haven't removed the eye, it's a good question for your radiation oncologist, and it needs to be a conversation. But we know certain things from the lacrimal gland carcinoma literature that, when a tumor crosses the midline, if it goes the vertical midline, you're going to have much higher risk of corneal toxicity. when the tumor touches the optic nerve, you're going to have much higher likelihood of optic nerve damage. Why? Because they have to treat that area. Any place that tumor touches, they have to treat, right? So it's really like that.
Ma'am, we also have the next question as, in cases of presumed diagnosis of, say, Ewing sarcoma, is there a topographical variation in the location of the tumor in a primary Ewing sarcoma versus a metastatic Ewing sarcoma?
Yes, I have seen radiation used in both conditions. But of course, in the metastatic Ewing sarcoma to the orbit, it's palliative in nature, right? I mean, we're not as optimistic there will be a cure. So we're not going to be perhaps as aggressive with the radiation dose. In the cases of primary Ewing sarcoma, yes, we use radiation and we use surgery, hopefully eye-sparing surgery, and we use chemo. Now, because it's so chemosensitive, like in that case that I showed you, the only surgery that patient had was a diagnostic procedure to establish the diagnosis for Ewing sarcoma. Then he had chemo and radiation. It had such amazing response. There was really no need for additional surgery. There was a little small focus, as I showed, remaining in the sinonasal cavity. That was actually just endoscopically removed, and it was scar, right? So when we say surgery, in most cases of primary Ewings, this is not for all of them. I mean, it's a really rare entity. But if they're responsive to chemo and radiation, and you see that the lesion has responded radiographically, then I think you could try to avoid exenteration. But that's not for every patient. In the cases of primary Ewing sarcoma, in the cases of metastatic to the orbit Ewing sarcoma, treatments are palliative. But yeah, it would probably be chemo and radiation.
Thank you, Dr. Esmaeli, for this wonderful lecture. I think what you explained about neoadjuvant radiation for SFT, that was really, really interesting. But what I wanted to ask you, in your practice, when do you advise adjuvant radiotherapy for SFTs? Which are the conditions where you would...
No, that's a really good question. It's obviously a judgment call. I do it for patients who already are recurrent. They've already have demonstrated over time 2 or 3 recurrences in the orbit. I've used it because, in those cases, I just don't think I'm a better surgeon than the next one. I mean, I've done this long enough to know it's not really the surgical technique. I mean, if a lesion has recurred 2 or 3 times over time, chances are the lesion is microscopically seated in the orbital fat. And if you're not going to do an exenteration, chances are they're going to recur again over time. But if it has a low mitotic figure rate, it's probably going to be many years before it recurs. So, you still have bought the patient some time, as long as the mitotic figure rate is low. But situations where I have used radiation, one is multiply recurrent lesions. The second situation might be a patient that, again, it goes to residual or recurrent. I had a recent patient that was referred to me from another university. Very good surgery was done for a solitary fibrous tumor, very big tumor that was into the orbital apex. But a small amount had remained near an extraocular muscle, appropriately so. I mean, if that surgeon had gone after that little piece, already the patient had diplopia from surgery, from extraocular muscle scarring. But had they gone for that final last little bit, probably even more morbidity to the eye. So they left that tiny little, like 5% behind. Well, that 5% of the mass I follow because choices were okay and low mitotic figures. So, and good functioning person. So choices are exenteration, careful observation, radiation. So I carefully observed this patient who was highly functional. After 18 months, it started to grow. That tiny little thing started to grow. At that point, we did radiation. Now, is that the right time to do this? For that particular lesion, yes, because it was a very deeply seated orbital apical mass, it's tiny. We would have to go digging in amongst the extraocular muscles posteriorly and causing more morbidity. It made sense to do radiation. So I guess my take-home message is it is a bit of a judgment call case by case. Radiation does have side effects also, even though 50 grays, but still, it's still some risk to the surrounding tissues, dry eye for sure, if nothing else. So, and you can only usually just do it once. So, you have to be careful when you do it, so you can only deliver it once. Other than if you do an exenteration, then maybe you can radiate again with a free flap. But so you have to be very careful when you do it. So I would do it for recurrent cases that are difficult to remove. I know upfront I'm going to have difficulty because already there's been an incisional biopsy. It's multilobular. It's big. Maybe it will shrink. Maybe I'm hoping it'll shrink, but it's not a guarantee that it would shrink. So those are the situations I have used it in. I hope it's helpful. It's not so black and white, and it's a judgment call case by case.
Thank you. I think that is also how we go about while treating our patients. The second question I had was regarding the follow-up of patients with rhabdomyosarcoma. When do you repeat the imaging after the child has been treated with surgery, radiation, chemotherapy? How often do you repeat the imaging and the PET scan and the systemic evaluation?
Sure. So I think most often it's the pediatric oncologist that's doing the surveillance. So a lot of orbital surgeons get out of the picture after their initial encounter. But because I work at a cancer hospital, I've had the opportunity to see how often things are done. I mean, following the sort of children's oncology group protocols in general. But I try to make the point that the 12-week point is really important. This has been documented in pediatric oncology literature and also in that paper that we did. So by about 12 weeks, most patient has finished significant amount of chemotherapy, and some of them have already started radiation and even finished radiation. So I think 12 weeks is really important. Statistically, it correlates with ultimate outcome. So if I were kind of an orbital specialist that wanted to remain involved in the imaging studies that are being done by the pediatric oncologist, I would say the 12-week point is really important. That's just about 3 months. And then in general, for soft tissue sarcomas in the orbit, we tend to do surveillance for the first year every 3 to 4 months as a general rule. That is not just for rhabdo. I mean, even my SFT patients, the one that I'm a little worried about, or the recurrent ones, initially after treatment, we do every 3 to 4 months the first year. You may increase the interval if they're doing really, really well to maybe every 6 months. And then if they're really long-term survivors and nothing's happening, especially in the case of rhabdo, because more than 90% are cured, then less and less so. Maybe once a year up to year 5, and then only as needed beyond that for the pediatric rhabdo. For some of these other adult sarcomas, you may continue with imaging for year 5 and then as needed.
All right. So the 12-week mark is from the time of the surgery?
From the time of initiation of treatment, right. Because you may do your surgery and not start treatment for some time. So from the time you start treatments, from the time you get them to chemo, which is the first treatment, right? For most patients, it's chemo.
Okay, right.
And at some point, radiation is introduced.
Yes.
In most cases, it's 4 to 6 weeks later. Sometimes it's a little later down the road. Right. I think for orbital surgeons, one take-home message I've learned that it's a source of common miscommunication is that if an orbital surgeon communicates with a pediatric oncologist, that I really feel like I got this. I got all of it. If you are careless and say that, a pediatric oncologist who may not be very experienced or has seen this before or know exactly what you're talking about, they're going to try to avoid radiation therapy because they're going to say, "Oh, you removed it all." But we know that, as most orbital surgeons would agree, that unless you do an exenteration, you're going to leave some microscopic disease behind because you're trying not to remove extraocular muscles. You're trying not to damage the globe. You're trying not to give a ptosis to the patient. So basically, it should be assumed that all cases have microscopically positive margins. And that communication with the pediatric oncologist and the radiation oncologist is really, really important. I think a lot of the cases that fail and keep getting recurrences and then gets to the point where it's really no longer curable is because of this lack of understanding or poor communication. And there are attempts at making the chemo regimen less and less aggressive for orbital rhabdo. And I think that is an evolving field, because then there's some cases of even embryonal rhabdomyosarcoma that short duration chemo may not be adequate, and because there are genetic variations even amongst embryonal rhabdomyosarcoma. So I think those are the cases that may not, you may not have good response at 12 weeks, and you need to be really vigilant on that. Stay on top of that.
All right. And in case of recurrent rhabdomyosarcoma, does your management differ in terms of when the recurrence is happening at what point, like within a year of the radiation or the last treatment, or beyond that?
I suppose if it's just within the first year of treatments in general, you might consider that not a recurrence, but a residual mass. That's the distinction, right? I mean, the point of that series that I shared with you, it's in AJO, you can look up the details. The point was that there are some cases, about a third of our cases, where there's something residual remaining on imaging. And that doesn't always mean bad, because there's some cases that just remain dormant or continue to disappear over time. Some of them went away at 7 years. I mean, I don't know what to make of that really exactly. Is it just the patient's host response continues to take that long? For those, that was a retrospective study, and there could be variations in data gathering and things like that. But generally, from a practical standpoint, I think lesions that are just remaining after treatment, early after treatment, that's a little different than you had complete disappearance and then boom, it comes back. That's a full-on recurrence, and I think we should worry about those. You need to rebiopsy that, see what is it active tumor. That's a recurrence. But when you have just a little residual lesion remaining dormant over time, that's different.
Also, in your practice, when you're suspecting sarcoma, do you use frozen section, intraoperative frozen section in all cases that you biopsy, or only in certain specific cases? Do you wait for the final pathology?
Yeah, good question. Good practical question. I think I do frozen because I want to know I'm in the right spot only. And they will tell you it's a small blue cell tumor. That's it. I mean, because I can't really tell you much beyond that. Or I might want to know, like, is it a cancer or is it an inflammatory lesion? Because let's say, I don't know, it could be a case of a Langerhans cell histiocytosis and I want to inject steroids. I mean, there could be a practical reason why I kind of want to know if it's cancer or not, right? So only for that, because beyond that, frozen cannot tell you really much of anything else. They're always going to defer to permanent for sarcomas.
Thank you so much.
You're very welcome. Yeah, thank you for the good questions.
Thank you so much, ma'am. Those are all the questions we had for tonight for you. Thank you so much for sparing your time, and good luck for the clinic upcoming for you.
I know, I need it. Now the day is ahead of me. Thank you so much, guys. It was really fun, and I hope it was helpful.
Yes, ma'am, surely. Before we conclude, I have a small announcement to make. We meet next on the 19th of January for an international masterclass on vascular tumors of the orbit by Dr. David Verity. Thank you so much.
Thank you.
Thank you.
Bye. Have a good day. Good evening. Bye.
Bye-bye.